I'm going to go over the epicardial pacer wire removal procedure. It's typically done on a patient that's had cardiac surgery. Like in our case, our patient has had bypass surgery. It can also be done in patients that have other cardiac surgeries or valve replacement. The purpose of the surgery is to have pacing on a patient post-surgery to ensure that they have adequate cardiac output and also to make sure that they're not having any arrhythmias. So the wire is typically removed 24 hours before discharge to ensure that if there's any complications, they can be remedied and the patient isn't sent home with any issues. The wire is in place usually for 3 to 5 days. If you look at the dressing, it's on the 12th and today is the 16th, and the patient's going to be discharged early Friday morning, so we want to make sure that it's taken out now. Before the procedure, we want to make sure that we have a PTT INR and fractionated heparin to make sure that the patient doesn't have an INR that's above 1.5 or 2. Those are the therapeutic levels. You also want to make sure that the platelet count is above 50,000. All this is to make sure that it helps decrease the chance of bleeding. If the patient has a heparin drip, we want to make sure that we shut it off at least 2 hours prior to the procedure. We want to make sure that the patient has electrodes hooked up to an ECG to monitor their heart. We want to take vitals. We want to explain the procedure to the patient so they're aware of what's going to happen. We want to give an analgesic ahead of time to help with any pain or discomfort or burning that might ensue when the procedure is going on. We want to do a full assessment just so we have something to compare it to after the procedure happens to see if we can, if we notice any changes in the patient's baseline. So we're going to put the patient at a 30-degree angle. We're going to check the patient's IV site, flush it, make sure it's patent in case we need to give any emergent drugs. Obviously we did our hand hygiene and had gloves. We have the crash cart available with all the meds to make sure that in case we need anything, it's close by. We did our 2 patient identifiers. We have a knowledge of where the patient's wires are at. If they were on the right side, it would be the atrial. If it's on the left, it would be ventricle. They can have it both, but our patient has just the left. If we had both, we would remove the atrial first, and then we would take the ventricle out after checking the rhythm in between. So now that we did all that, I'm going to check a metal surface, touch a metal surface, to make sure that there's no static charge. Since it's a metal wire, we obviously don't want to have anything crazy with that. So we're going to take off the outer dressing first. And as we can see, our patient has lovely sutures. We're going to take our chlorhexidine in order to sanitize it. We're going to clean at a 3-inch radius around it. And we're going to do it for 2 minutes to help reduce the risk of infection. And then we're going to do our suture removal. So you're not going to cut the wire. You don't want to cut the wire. You want to just cut the sutures out. And then you're going to take it and you're going to gently pull. If there's any sort of tension, you want to stop and you want to call the surgeon because any tension is bad and it could rip. So you pull it out. And then you're going to look at it and make sure that it's intact. Make sure there's no tissue on the end. There's no tissue. If there was tissue or it wasn't intact, you'd want to call the surgeon. So we're going to dispose of that. And then we're going to put a sterile dressing over it. Putting a sterile dressing over it helps reduce the risk of infection. So the patient's going to remain on bed rest for an hour, and we're going to check vitals every 15 minutes, obviously to check for any arrhythmias or any other issues, any sort of bleeding. We're also going to notify the patient for some signs and symptoms to be aware of if he has any dyspnea, if he has any chest discomfort, pain, or anything like that. We want to have him notify us. We're going to keep the ECG monitoring on for 2 hours at least, so it can check for any dysrhythmias. Hypotension can happen up to 2 hours after the procedure. And some of the side effects that can happen is obviously bleeding, dysrhythmias, and cardiac tamponade. So we're going to look out for the Beck's triad and pulsus paradoxus to make sure that none of that is an issue. The end.